Thank you for the kind invitation to talk here today, and I thank the chairs for their kind introduction. Today I'm going to talk about a slightly different topic that was introduced. I'm going to talk about degenerative disc disease and regenerative medicine. Regenerative medicine is now used worldwide, and we typically in Australia use stromal vascular fraction for osteoarthritis. We also use it in the USA, the Middle East, and here in India under Sahaj therapy for osteoarthritis, the treatment. The conservative management of degenerative disc disease is generally physical therapy, pain management, and epidural steroid injections. And then following the failure of those conservative treatments, we then do conservative surgical options such as decompression, and then more structural intervention such as spinal fusion and total disc replacement. So when we talk about regenerative medicine, what we're talking about is a paradigm shift away from surgical operations and pharmaceutical to self-healing with one's own cells. So the aim of cell-based therapies is to repopulate the degenerative discs and restore functional tissue. Approximately 65 million Americans suffer from lower back pain annually. And the economic cost to the community is approximately $100 to $200 billion annually. So it's a huge cost, both personally and economically, to the community. Mostly degenerative disc disease is asymptomatic, but when it becomes chronic, you can see that the quality of life goes down. It's a debilitating condition with severe leg pain, difficulty standing and walking, and weakness and numbness in the legs. And the traditional treatment options generally are ineffective. So, as we'd had a lot of experience with osteoarthritis, we are now looking at doing clinical trials into the degenerative disc disease with stromal vascular fraction. So when we look at a typical disc, this is a healthy disc here. It's got the nucleus here, which is nice and plump and gelatinous. And around here, around the outside, is the concentric rings of the annulus. And when the disc typically degenerates, you can see it's highly desiccated, the nucleus. It's generally disorganised, and also the annulus around the outside here is typically disorganised. Going down to the cellular level, you see increased cell death, decreased protoglycans and collagen II synthesis, loss of the water-retaining protoglycans, and importantly, the nucleus is unable to withstand that compressive loading. So there's strains on a number of other components of the motion segment, such as the annulus and the Z joints. So what are we fighting in this degenerative disc? We've typically got a hypoxic environment, which means we've got low oxygen, low glucose, low energy for the cells, low pH, and very high pressure there. And also typically avascular tissue, one of the largest in the body. But this is not all bad news for cell therapy, in that they typically respond to a hypoxic environment and to the lack of the blood vessels. Where are we at here with the preclinical animal data? There's been a number of studies done on cell therapies with animal data in degenerative discs, and Duffenbach did a meta-analysis there, looking at 6 randomised trials there in animals that met their criteria in a number of different species. Overall, in all of these studies, there was a 23% increase in the height of the disc in compared to the controls. So that gives us some great hopes that we can apply this in the clinic. One of the most important studies done was by a large organisation, Mesoblast, when they looked at mesenchymal progenitor cells. What they took was a sheep, and they destroyed the discs, artificially destroyed the discs in 3 of the discs and left the top discs as control. So you can see here there's the typical white area indicating that it's high in water content, the discs, and the black indicating the discs have been destroyed. And they injected their MPCs and hyaluronic acid into the discs, and also hyaluronic acid alone. This is your typical control when they've excised the discs after 6 months. And you can see here the nucleus is black under this histopathology, and here's the outside. And this is a typical low cellular content. Over here, we have the destroyed discs here. So you can see that they're definitely not healthy. And they maintained this status. When they were injected with the MPCs, you can see that the disc is looking very close to returning normal. You can see the black area, and you can see some cell population, some speckles here, which indicates the cells are there. Mesoblast then took these cells and put them into a clinical study in 100 patients worldwide, and they randomised them to normal saline, hyaluronic acid, low-dose MPCs at 6 million cells, and high-dose 18 million MPCs. The results from the study so far, when we look at this is a controls, this is the black, the blue is the low dose, and the green is the high dose. And what we saw was that half the patients had minimal to no back pain after 12 months, which were in the treated, compared to the control where 80% of the patients all had back pain. When we lower the bar down to a reduction of 50% in back pain, which is this graph here, we can see in the treated group approximately 70% had a 50% reduction in back pain after 12 months, and approximately only a third in the control group had a reduction of 50%. So some good results there, with some fairly good results there with the MPC study by Mesoblast. But then we come to those real-world issues for all the people in the clinic. These cultured MPCs are likely to be expensive. It's been estimated in some of the literature, above $30,000. You've got the risk of being tumorigenic with cultured cells, as you're unable to test every single cell for mutations when you culture the cells. The other major issue which is going to be faced is allogeneic. There have been instances of immune reactions with multiple injections, and this study only did 1 injection of cultured cells, of allogeneic cultured cells. So our proposed study is using our autologous cells, stromal vascular fraction, which is obtained by mechanical means called StroMed. It's a same-day, single-day procedure on the day. So you can obtain these cells and inject them on the day in the same surgery. We're also going to inject a nanoscaffold. So this scaffold is one we've been developing there in the States with our colleagues, and it enhances cellular migration, proliferation, and is dissolvable and injectable into the disc. And also a PRP sealant to help with that pressure to keep those cells in there with the tissue scaffold, the nanoscaffold, so they can do their work. So when we obtain these cells, we obtain it by a mini liposuction. This will be approximately 20 to 50 mils of fat obtained from the stomach. It's quickly processed within an hour in the surgery, and then you have the cells, and these are injected. So it's a fairly quick process to obtain the cells and then use them to be injected in the disc. When we talk about stromal vascular fraction, okay, what's it able to do? It's been shown in vitro to differentiate between chondrous-like cells. It can produce proteoglycans and type 2 and collagen. So when we obtain it, we obtain stromal vascular fraction from the fat, from the lipoaspirate, from a mini liposuction. What we see here is a globule of fat. And in amongst it, it's been stained with a nuclear dye called DAPI. And in amongst that, you can see here they're like these roads. This is the blood vessel, the avascular tissue running through the fat. And this is typically what we call the stromal vascular fraction when we obtain these cells. So this is an EM taken by Arnold Kaplan, and what you can see, these red cells are actually pericytes wrapped around the blood vessels, and these are also important. So we obtain a number of different cells when we obtain a stromal vascular fraction. Basically, we're just removing the fat cells. We obtain the mesenchymal cells, the pericytes, the EPCs, the endothelial progenitor cells, hemopoietic blood cells. So quite a number. And it's estimated that approximately 60% by some people in the literature are regenerative cells. So this is a very powerful mix of cells that we're injecting, and we've seen those results with osteoarthritis. We're injecting our nanoscaffold, and the concept behind this is there'll be space filling and there's protection of the nucleus. And the power of the nanoscaffold cannot be underestimated when we begin using this. This is an example here where we've used it for some wound healing, and this is a bed sore, which has been non-healing. And it's quite huge and deep, and this here is after 8 days. So the power to cause cells to proliferate and then to degrade quite rapidly is what we need. We want rapid tissue growth and enhancement of healing within the disc. And also the fibrin sealant is one aspect of our combinatorial therapy. Our preclinical studies have been quite significant, and to give you an example here, we like to use real-world clinical studies. We don't like to artificially destroy discs. So here we've got a history of a particular dog which was presented to us, 2.5 years old, and it had a history of dragging its hind limbs for 3 months with minimally controlled urination, some feeling left in its hind legs, and the urologist who examined the dog recommended euthanasia. So due to compassionate use, we used our cell therapy with nanoscaffold in the US, and we prepared the Stromed with the nanoscaffold for 15 minutes and then administered the PRP. And we intravenously injected those cells by fluoroscope guidance between the L2 and L3 and L4 and L5. We also gave a cc IV of the cells with sterile saline. Post-procedure, at 30 days, there was no measurable improvement in the dog. At 60 days, we started to see using its hind legs for the first time, and the owner continuing with physical therapy. And importantly here, at 5 months, the dog was clinically normal. There was no deficit in the movement of the dog or the urination. So that's quite a powerful for both the dog and the owners in the results obtained. So we're currently doing a clinical study in the USA. It's a prospective non-randomised of 90 patients who have chronic leg and or back pain. They failed traditional therapy for hyperintense zones of bulges, herniation and disc height issues. And we're treating them with the Stromed and with the nanoscaffold and the platelet-rich plasma. And we're currently tracking the outcomes with the typical ODI, the Osgood Disability Index, and follow-up MRIs at various endpoints from 6 months to 2 years. The current risks involved with the trial is osteophyte growth in the spinal canal, the nanoscaffold that we're using, the disc space infection, worsening of disc degeneration. So that's the risk inherent with this study. But overall, based on the preclinical data and the results that we've seen currently, we believe this holds great promise to helping with the disc degeneration problems that we see in the community. And we will hopefully, in another 12 months, we'll be presenting the data here of this study. And it's just another direction that we can use stromal vascular fraction and regenerative medicine in health problems. Thank you.